Now, I want to move on a bit to the matter of corneal transplants. The transplanting of corneas is one of the matters that has now found its way with regularity into the Tobago healthcare space, in that over the last 6 to 8 months, there have been a marked increase in corneal transplants. These transplants are done by a team of specialists who are not part of the standing staff of the RHA. These are hired professionals who come in and do as many transplants as they can fit into one day. Naturally, the Tobago public has benefited from this resource. However, questions have arisen. These specialists, of course, are generously recompensed for every transplant they carried out. They bill by transplant. And while there is no doubt that there is a need for such a service, questions have arisen as to the source of the corneas used for transplant. As you are aware, Trinidad and Tobago has no eye bank where donated corneas are stored. Given the sheer number of the transplants occurring in Tobago over the last 6 to 8 months, it is clear that these transplants were not sourced from willing donors. And when I say willing donors, it is clear that several dozen people didn't come forward and say, take one of my corneas for transplant. So that it must be that these corneas were harvested from deceased donors. And corneas are one of the organs that can be harvested from the dead. The Secretary for Health and the TRHA is obligated to disclose, given their irregularities on a day-to-day basis that occurs within the TRHA, and the remuneration of external staff for doing these transplants, the TRHA is obligated to disclose the source of these corneas. Where are you getting these corneas from? So you can have this large amount of corneas on staff, so you can then pay a specialized team per corneal transplant. Where are the corneas coming from? Have they been imported with the TRHA observing all the protocols for importing biological samples? And if they have been harvested in Trinidad or in Tobago, where are the appropriate consents from the families of the cadavers? It is gruesome to consider that there may well be happening in paradise the unauthorized harvesting of organs from cadavers occurring in the middle of paradise, all to be able to direct funding and recompense into the hands of a select few. This is a gruesome and worrisome matter. To this end, and in the interest of transparency, the Tobago Forwards has again, using the mechanism of the Freedom of Information Act, demanded the following information from the TRHA. All data records on corneal transplants occurring at the Department of Ophthalmology, Scarborough General Hospital. The name of the head of the department, the date of the establishment of that department, the number of corneal transplants performed from the date of the establishment of the department to present, the source of the corneas used in the transplants. Documents and/or certificates confirming compliance with importation criteria, for example, customs documentation and Division of Health and Services classification of the corneas if imported, permission from relatives if the deceased are deceased locally. Now you might ask, why are these matters important? Because certainly as services provided, people are benefiting. If the corneas, as we rather suspect, are harvested from deceased persons, then who is really affected since the person is already deceased? But we in Trinidad and Tobago have a culture of honoring our dead. And it cannot be that our dead relatives are being harvested for the financial gain of persons who are operating under the guise of providing a service to other persons who are indigent and cannot afford to ask the relevant questions. We cannot be, in the face of international condemnation on organ harvesting, we cannot be part of the problem. And again, I want to reassure that this is not an idle request. This is a request that, if not met within the statutory time frame, will be followed promptly by an application for judicial review to compel the TRHA to provide the information. Finally, today, I want to touch on the matter of ambulances and ambulance drivers in Tobago. Prior to March 2015, Tobago was in the unenviable position of having a fleet of ambulances numbering 1. A fleet of 1. In early March 2015, that matter changed, and 10 ambulances were added to the complement of Tobago ambulances. Nonetheless, we have noted that this has not alleviated any or all of the problems associated with ambulance care and health care provision in Tobago. Rightly, we should have ambulances stationed in Lowlands, in Scarborough, in Roxborough, in Charlottesville, and in Palatuvere, Castara. Currently, this is not the position. The complement of ambulances, which has now grown to 11, is still largely not in use. In fact, less than half of that number of ambulances is in use on the roads in Tobago. We also need to consider the categories of ambulance service licenses that we possess in the TRHA, and whether the staff can actually fulfill the requirements to obtain licenses of different classes. The classes of licenses that you can acquire for an ambulance are outlined in the schedule of the Emergency Ambulance Service and Emergency Medical Personnel Act. And there are 3 categories of ambulance licenses. The first is basic life support. Right? You can have a basic life support license, which in essence allows you to ride to the hospital in an ambulance, and you'll have access to oxygen. That's basic. This, of course, is inadequate, because it is widely accepted, for example, that administering aspirin can help if a patient is having a heart attack. So if you only have a ride to the ambulance with oxygen, nobody's going to give you an aspirin if you're having a heart attack. And the EHA and the ambulance drivers, the EHA personnel, do not administer any drugs in the ambulance. Now, we have to consider whether and why we don't have the other categories of ambulance licenses, which is Advanced Life Support 1, where you have transportation by ambulance and assessment. What is going on with this patient? What is the data I am going to give to the doctor? What is the patient's reported condition at the time of the dispatch? And it allows the tech to give one procedure above basic. We have to consider why we don't have Advanced Life Support Level 2, which of course would be transportation by ambulance and the provision of some services, including administration of medication by either IV or bolus or continued infusion, central venous line, cardiac pacing, surgical airways, etc. Now, these things are important because increasingly in Tobago, people are being delivered by ambulance and dying. This matter has been brought into stark relief with the death of Fitzroy Carrington on or around March 30th, some 2 weeks after 10 ambulances were added to the fleet. Mr. Carrington, who was complaining of chest pains, was taken to the Scarborough General Hospital by ambulance. But what, if any, treatment did he receive in the ambulance? In fact, he was given a ride to the hospital in the ambulance. deposited in the hospital A&E by ambulance technicians, by EHS, and left there unattended for several hours, after which he died. What was the intervention that that EHS did in the ambulance? But more importantly, what were they authorized or trained to do? So in addition to not utilizing the full complement of ambulances, we also have a paucity of staff and an absence of staff that appear to be trained beyond basic. This cannot be adequate in a society where the tourism product is paramount.